This will be our first look at Chapter 10, Respiration During Exercise of our Exercise Physiology textbook. In order to get ready to talk about what happens to the respiratory system or how it functions during exercise, we should look at some of the anatomy and some terms associated with respiratory system construction and function. Here's an impressive list of functions of the lungs. By the time we've finished our chapter, every one of these will be familiar and you'll be able to say something about them. So, first of all, the term respiration. We talk about the lungs. Respiration is talking about the exchange of gases between the alveoli, the air sacs in the lungs, and the blood in the lungs that travels through the lungs. In order to make that happen, we're going to have to ventilate the lungs, and that refers to moving air in and out. Then, once we deliver the oxygen and the oxygen-rich blood to the tissues, the cells will extract out the oxygen to use for energy production, and in so doing produce CO2 that they will add to the blood, and will send that blood back to the lungs to be refurbished. So, need to exchange gases in the lungs, but here's something you may not have known. We need to control the pH of the blood. The lungs are the first line of defense. Well, actually, the first line of defense, the first organ of two that controls blood pH. So, when we send the blood to the lungs, we're going to be replacing the oxygen that was taken out of the blood in the tissues for the use by the cells. We're going to remove the CO2 that was placed in the blood by the cells during cellular respiration and breathe it out of the body. And as I said, we're also going to be controlling acid-base balance. We're going to make sure the pH of the blood stays constant by virtue of the lung function. Ventilation is just the mechanical movement of air in and out of the lungs. Thinking of it as an air pump, just pumping air in and pumping air out. Diffusion is what's going to happen with the gases. Diffusion refers to the movement of molecules, or ions in other contexts, from an area of high concentration to an area of lower concentration. So what's going to happen is oxygen is going to diffuse in the water on the surface of the air sacs and then move from high concentration there where it's entering the surface and then over into the blood. CO2 is going to diffuse from the blood where it's higher concentration as it arrives in the lungs over to the air sacs where it's lower, and then we're going to breathe out that CO2. Here's a little schematic diagram. We send some blood to the lungs. We're going to add oxygen just as much as can possibly be carried by the blood, send that blood to the tissues, and oxygen is going to diffuse out into the fluid around the cells. The cells will extract the oxygen, and then we'll send the blood that's already had oxygen removed from it and CO2 added to it back to the lungs. Get rid of the CO2 out into the atmosphere and bring oxygen in. Here's a little anatomical drawing of the lungs to make clear a couple of terminologies. The upper respiratory system refers to everything above your larynx or voice box. So your nasal cavity or oral cavity, your throat, which is called the pharynx, your voice box, the larynx. The lower respiratory tract refers to the trachea, all the bronchi and their branches, and finally down to the air sacs, the microscopic air sacs of the lungs. That's a sterile area as opposed to the upper area, which is full of bacteria and so forth. All that plumbing, nasal cavity, pharynx, trachea, all the branches of the bronchi, all those pipes are called the conducting zone of the lungs. Their sole purpose is to get fresh air down into the lungs so that we can extract oxygen and place it in the blood. Whereas the respiratory zone of the lungs refers to anywhere there's actually alveoli, microscopic air sacs, and it's across the walls of those alveoli that the gases diffuse. No gases diffuse through the walls of the conducting zone of the lungs, of the pipes. It's only in the alveoli. Here's an interesting phenomenon you should know about the lungs and the pulmonary system. Here you can see the lungs residing in their body cavities called the pleural cavities. And the pleural cavities are lined with a membrane called the parietal pleura. It's a layer of cells that secretes a small amount of a lubricant fluid. The lungs themselves are covered with an identical pleural membrane, it's called, a serous membrane that also secretes a little bit of lubricant. And so these two membranes rub, they're friction free, so as the lungs expand and contract, they can glide along the surface of the pleural cavity with no friction. The lungs are made up of millions, hundreds of millions of microscopic air sacs, but they're like little tiny elastic balloons. When you inflate them, they're elastic, and so they're stretched out like a balloon, and you can sense that tension in the wall of a balloon. Just like if you let go of a balloon that's been blown up, it'll fly around the room as the elastic walls push down. That's called elastic recoil, push inward, and the air comes shooting out. Alveoli are exactly the same way. So all the time, your lungs, all those alveoli are pulling inward. You never let the lungs, the alveoli, collapse. They're always partly inflated, so they're always like a blown up balloon. Their walls are stretched and they're elastic. So that's an inward force. The chest wall has now been pulled in by the work of all those alveoli to the point where it just can't be pulled in anymore. It's resisting any further pulling in. That's an outward force because the chest wall has some structural integrity. It's made of cartilage, bone, muscle, and it can only be pulled in to the point where the outward force by the chest wall is exactly equal and opposite to the elastic force of the alveoli pulling in. And at rest, your lungs and your chest wall reside in this kind of tense balance of forces. And then when you want to breathe in, all you need to do is expand a little bit and breathe out, contract a little bit, but the forces are always present. An interesting sort of effect is that there's like a vacuum in this gap. There's this very narrow space between the pleural membranes. If something were to happen so that a pathway for air from the atmosphere to get into this intrapleural space were made, then air would rush in there and the lung would collapse down. Once we can let some air fill up this space, the tension will be lost, the lungs will just collapse. Leave a big hollow space in here. Or, what if we tear the surface of the lung so that air can go through the bronchi, through a population of alveoli, and then go out into this space here? Then the same thing will happen. There will be a collapsed lung. Sometimes when people are playing sports and breathing very, very vigorously, they may have such an injury to the lung, and air will escape from the lungs into that intrapleural space, or pleural cavity as they're calling it, and the lung will collapse. A painful condition that produces a profound sense of shortness of breath, difficulty breathing, and we need some medical assistance to reinflate that lung typically and get things back to normal. Here's just a little diagram illustrating the branching of the bronchi. The trachea branches first into the primary left and right bronchi, right and left I should say. Typically we show illustrations from an anterior point of view. And then we just keep on branching about 23 times until we get down to we pass through the conducting zone with 23 or so branches of the bronchi until we get to what are called respiratory bronchioles. The smallest bronchi are called bronchioles, and the respiratory bronchioles are ones that are so small they have alveoli, air sacs attached to them that can actually diffuse gases. And finally we get down into the area where there's just clusters of air sacs or alveoli. And here's a larger illustration of the air sacs. Here's a conducting bronchiole. Here's a respiratory bronchiole because it has some alveoli attached to it. And here's a cluster of alveoli attached to it. About 300 to 500 million alveoli make up your respiratory membrane of your lungs, it's called. The membrane across which oxygen and CO2 must diffuse. It's been estimated that if you took all of the alveoli and flattened them out and attached them all together in a sheet, they would cover an entire soccer field. So you have a very large surface area for gas exchange, which is very important. So every air sac, every alveolus is a little balloon made of thin cells, alveolar cells. And then surrounding the alveolus, this little air sac, we've looked at it like a cross-section through the air sac so we can see the edges of these cells, but it would normally be a sphere, essentially. There's blood capillaries covering almost the entire wall of the alveolus so that blood coming from the tissues that had oxygen extracted from it comes alongside of the capillary, and oxygen diffuses into the blood until it's completely saturated, nowhere to put any more oxygen, and we send that blood out to the body for cells to get the oxygen. In addition, blood coming to the lungs has extra CO2 that was placed there by the tissues, by the cellular respiration, and that extra CO2 will diffuse from higher concentration in the blood to lower concentration in the alveoli, and then be breathed out into the fresh air. There's no CO2 essentially in the air of the room or outside, just in the alveolus coming from the tissues. Well, how do we actually accomplish ventilation, breathing? Here it is in words describe what I'm going to show you in the next slide. How do we accomplish bringing air in and bringing air back out again? That's ventilation. What we're going to do is, step one, for inspiration, we're going to increase the volume of the thoracic cavity, the lungs. How are we going to do that? Well, at rest we do that by contracting the diaphragm muscle. What that does is it pulls downward and pulls the lungs down with it and just increases the volume in there. If we're exercising, we'll use some more muscles to elevate the rib cage, lift it right up, and as we lift it up, the sternum is farther away from the spinal column, and there's going to be an even greater increase in volume of the lungs. So when we have the lung volume increasing, the pressure drops. So airflow depends on a difference in pressure from one place to another. Higher air flows from higher pressure to lower pressure. There's going to be some opposition to flow. It's not infinitely easy for the air to move. It takes some time for it to go rushing through all of the bronchi. That's called resistance. So anyway, we increase the volume of the lungs, and as a result, the pressure drops. When you increase the volume with a set amount of gas present in a container, the pressure goes down. So now the pressure in the thorax is lower than atmospheric pressure outside, and air just moves into the lungs from higher pressure to lower pressure. We let some gas exchange, and then we expire air. How do we do that? Well, at rest, we simply relax the diaphragm. That's the sole mechanism of reducing the volume in the thorax in order to expire air. That's how we get the air out. We reduce the volume, which raises the pressure, the pulmonary pressure, because all those alveoli are little elastic balloons, and all we have to do is relax the diaphragm, and we have elastic recoil of all the alveoli, which will reduce the volume for expiration. And when you reduce the volume, that increases the pressure, and air moves out from higher pressure in the pulmonary system or in the lungs to lower pressure outside. So that's the ticket. So during exercise, we have extra muscles helping us expand the volume of the thorax, and extra muscles helping us to reduce the volume of the thorax. So here's just a cartoon showing some of the muscles. Inspiration, when you're exercising, we're gonna contract the diaphragm, yes. We're also going to contract the external intercostal muscles to lift the rib cage, contract the pectoralis minor muscles to lift the rib cage. If you look in your textbook, it shows the pectoralis minor muscles right here in the anterior. We're going to contract the scalenes and the sternocleidomastoid muscles here, shown here, of the neck that are attached to the bony thorax and lift. And that's how we increase the volume to inspire air. When we're going to expire air, we're going to pull the rib cage down and collapse it and reduce the volume, raising the pressure. We're going to use the internal intercostal muscles to expire air. We're going to use the abdominal wall muscles to reduce the volume in the abdominal cavity, which will then push upwards and reduce volume in the thoracic cavity. And all those changes will help us reduce the volume and increase the pressure and blow out the air. So, again, we said air flows from higher pressure to lower pressure, and it's opposed by resistance in the airways. What affects resistance? The diameter of the airways. The smaller the diameter, the harder it is for the air to get through there, and the greater the diameter, the easier it is for the air to get through there. So, if we add some epinephrine and norepinephrine, we're going to bronchodilate. As we've said in the past, when we talked about the autonomic nervous system, bronchodilation increases the opening of those pipes and reduces the resistance. It's easier to move the air in and out. When you have inflammation, such as during asthma or bronchitis associated with COPD, that's going to cause bronchoconstriction, making it harder to move air in and out of the lungs. And people with COPD have not only destruction of the alveoli because of a disease called emphysema, they have bronchoconstriction because of inflammation in the bronchioles, bronchi and bronchioles. Asthma is an inflammation caused by irritation, or you could have an allergy. That both of those cases, we're going to produce some histamine, a drug or a substance called histamine coming from mast cells in your body. It's going to cause bronchoconstriction, make it harder to breathe. And we may need to get some epinephrine into the body in emergency situations using EpiPen so that bronchodilation will take over and allow easy breathing again. There's some terminology. We're going to look at pulmonary ventilation a little more directly. Measuring pulmonary ventilation is done by an instrument called a spirometer. And in order to understand what some of the volumes and capacities are that the spirometers identify, we should know these subscripts we're going to see from time to time. Tidal volume. That's the amount of volume you breathe in and out of your lungs at rest. Dead space. It's the amount of air that is occupied by the trachea, the bronchi, the bronchioles, all those airways, as well as the nasal cavity. All those spaces have volume in them. And when you expire old, expended, used air, that last instant before you inspire some fresh air, all those volumes, those spaces are filled with already used stale air. And when you begin to inspire, the first thing that happens is all that volume, around 150 mils of air, goes right back down into your lungs. That's called dead space volume. It's doing not a lick of good as far as bringing oxygen in until we get some fresh air coming in behind that, which will then contain a lot of oxygen. A stands for alveolar, inspired and expired. So let's go on. Oh, incidentally, pulmonary ventilation is illustrated by the letter V, and it should have a dot over it to indicate it's a dynamic process that we're going to average over a period of time when we talk about it. So these V's should have dots over them. It's a pain to put the dots on, so people generally are lazy and leave them off, just so you know that should be on there. So the tidal volume is the volume breathed in with each resting breath, each resting inspiration, each resting expiration. F is the frequency, breaths per minute, that you normally breathe. So pulmonary ventilation is just the tidal volume times the frequency. It's the number of liters per minute of air being breathed in and out. Pulmonary ventilation. But the problem with that is, if we just calculate pulmonary ventilation, we really don't have a good handle on how well the pulmonary system is working for the body. That's because dead space ventilation, the moving of that 150 mils of air up and down in the airways, doesn't contribute in any way to fresh air getting down there. So if we want to really know how much fresh air is getting down into the alveoli to help the body, we don't just want to know the numbers of liters per minute coming in, we want to know the numbers of liters per minute getting into the alveoli of fresh air. We can figure that out by calculating the alveolar ventilation rate. So V dot with an A means alveolar ventilation, and we figure that out by simply subtracting the dead space away from the tidal volume and then multiplying times frequency. And now we know how much fresh air per minute is getting down into all the alveoli in your lungs, the alveolar ventilation rate. That's a very valuable metric to know. Okay, join me next time for part 2 as we talk more about the delivery of oxygen from in the blood to the tissues and how that happens, and the delivery of CO2 from the tissues to the lungs and getting it out of the body and how those processes happen.